Hey everybody, here is a lecture on radiographic film quality. So some of the things that we are presenting in this lecture is only for analog systems. So analog systems meaning that these are systems that are still using actual film, specifically when we are discussing film density and contrast. However, there will be other things that we will be covering that can translate over from analog to digital or computer systems. So having a basic understanding of physics, which you guys have already had a few terms ago, to help know how to fix film quality issues will help. So some things to consider when you are assessing proper quality of a film is all of the required anatomy on the film and adequately visible on the film? How is the patient positioned? How is the tube tilt, if there is a tube tilt? Is there any patient motion that you can see? Is the image blurry? How's the film density? Is it too light or is it too dark? Can you see everything that you need? Is there a proper amount of shades of gray if necessary? Um, Considering if you're looking at the contrast, is it too high or is it too low? Are there any darkroom errors? That's only if you are processing actual film, but there will be other processing errors that you can see on computer or digital systems. Are there any artifacts present, whether it's outside of the patient, like on the patient's person, jewelry, or something like that? Or is there other type of artifacts, such as the marker? Is there only one exposure on the film? There can be instances of double exposure. So going to looking to see if all of the required anatomy is on the film. So specific anatomy is meant to be visualized on each view. So that's the point of taking that view. So when you're looking at the lower A to P lower cervical, you are expected to see all of the lower cervical. So if the required anatomy is not visualized adequately, then it's considered non-diagnostic, and therefore you would have to retake that film. So some reasons as to why some of the anatomy is not shown as it should be. Some of the lists that we have here, as you notice, it says it's not a comprehensive list, so other things could be considered. But some of the main things that you may see: poor positioning of the patient, poor positioning of the central ray, which will include incorrect tube tilts. Is the cassette tray pushed all the way in, or is the image over collimated? So when we're looking at this A to P open mouth view, you can visualize what a proper A to P open mouth should assess. We should be able to see C1 and C2 properly. And when we're looking at this, I can see the body of C3 and C4 much better than I would for the upper, what this view is supposed to be, to see the upper cervical. So we have poor positioning of the patient. So in this view, the patient is flexed too much, so the teeth and the hard palate are overlying C1 and the dens. As you can see, we can't see anything. So the patient should have their head extended a little more. So of course this view needs to be retaken so we can see the adequate anatomy. So evaluation criteria, what should we be seeing in a proper A to P open mouth view? We should see the lateral masses. We should see the transverse processes of C1. We should see the dens. We should see C2, the body of C2 more specifically. If the occiput obscures some of these structures, then the patient may be in too much extension. And obviously we see there's teeth in the way, so the patient has too much flexion. So looking at this P to A lumbar spine view, doesn't look too bad, but if you look closely, are we really seeing all of our lumbar spine? As I am going up, I see L2 through L5, but I'm only seeing half of L1, which obviously with a lumbar spine, we have to see all of our lumbar vertebra. So the patient is positioned properly. However, the central ray is actually too low and it's missing pertinent anatomy. So when we say that the central ray is too low, the central ray for a P to A lumbar should be around the level of L4. But in this case, I would say the central ray is probably around the sacrum. So as you can see, very low from what we need. So the central ray should be higher at the level of L4. So what should we look for when we are assessing a P to A lumbar spine? We should be able to see at least from T11 to the distal sacrum so we can ensure that we are getting all of the lumbar spine in view. And you want to be out far lateral enough to assess the TPs of your lumbar spine, as we can see here. And you also want to see the SI joints. So this is collimated pretty good, but again, that central ray is too low. Here we have another example of a lumbar spine view. This was taken in an A to P fashion. But as we're looking here, the positioning is good, the central ray is good. However, we are missing pertinent anatomy. We should be able to see, like we said before, evaluation criteria. We should be able to see from T11 to the distal sacrum. But we have this large gonadal shielding in front of the patient that is completely blocking our SI joints, basically our entire sacrum, and even our femoroacetabular joints as well. So retaking this image with either gonadal shielding that's smaller, or we can position the patient in a P to A fashion and eliminate the gonadal shielding for this view so we don't miss any pertinent anatomy. Also, just to make note of this lumbar spine, this is not of a human. This is known as a phantom study. So it's a model of the lumbar spine. So if you're looking and counting and saying, oh, they're missing a couple pieces, so that's why it's called a phantom or just a model spine. So that's what we're seeing here. Next, we have an A to P lower cervical spine view. So again, as you can envision what a lower cervical spine view should be, you should know that we should be able to see C3 through C7 at best for lower cervical spine view. That's the point of that spine view. However, when you're looking at this, we can see that the patient's mandible and chin soft tissues are completely obscuring majority of the vertebral segments. So as you can see, mandible and surrounding soft tissues are overlying and obscuring most of the osseous anatomy. There was no tube tilt that was used, and we've gone over what the tube tilt for an A to P lower cervical spine should be, which is 15 degrees cephalad. So in order to ensure that we are getting a proper view of all of the cervical spine, we need to utilize that tube tilt. So this film needs to be retaken with that 15-degree upward or cephalad tube tilt. And then here we have another example of an A to P lower cervical spine view. As you can see, we are not assessing the entire cervical spine. It almost looks like we're not almost, we are seeing just half of the cervical spine present. This is because the cassette tray was not pushed all the way in. So everything was done correctly. The patient was properly centered. The tube tilt looks like it was good. The person just, whoever took this x-ray, just forgot to close that cassette tray at the end, and they pushed that button, and that's what happened. So always make sure when you are doing your checklist, it's one thing to have the patient properly positioned, center ray properly positioned, but making sure that that cassette tray is also in its proper position as well. So as you can see, film needs to be retaken with the cassette firmly locked in the tray, and that metal tray that we have shown you guys is pushed all the way in. Here we have another example of an A to P lower cervical view. And we can see the entire cervical spine. The patient, there is a tube tilt. However, the spine itself is not centered on this film. So the cervical spine should be here, where I have outlined in that red. However, even though the patient isn't properly centered in that in this film, we do see everything that we need to. We have all of the vertebral bodies. The tube tilt is in its proper position because I can see all of the segments that I should expect to see on a lower cervical. It's actually collimated enough to where I'm not missing soft tissues because I can see. Let me do a better color here. I can assess the soft tissues, and nothing's been cut off. So as you can see, the patient, it was not properly centered. The cassette was properly centered. However, even though patient not centered, it does result in a little bit of, you do sacrifice a little bit of that film quality. The density is a little off, but we are seeing everything that we need. So a repeat study can be done. However, it's not necessary in this case. And here we have an example of an A to P knee. So if you guys can visualize what an A to P knee should show, you can see that we are missing a good chunk of our distal femur. As we can see, we're also getting a little cut off of this medial aspect of our tibia, and we should see a little more of our tibia and fibula. So as you can see, there's too much collimation. So of course, collimation is important because you want to make sure that the patient doesn't have a lot of radiation dose. However, you have to also make sure that we are assessing what we need to. So for a proper A to P knee, we need to see enough of that distal femur and proximal tibia and fibula. So this view does need to be retaken with the collimation opened up a little bit. So speaking of collimation, I know I have explained this to some people in the class. The X-ray beam should never exceed the size of our cassette. So if we have a cassette that's, say, 10 inches by 12 inches, that collimation should never exceed beyond the parameters of that cassette. It could be at the parameters of the cassette or smaller, never bigger, because you don't want to increase radiation dose for that patient. So some systems can automatically collimate to the size of the image receptor that you're using, or as we teach you guys, we'll show you how to put in the proper collimation at the X-ray tube. So the reasons we collimate, like I just said, you want to reduce patient radiation exposure or dose. And you want to make sure that if it's collimated tight enough, you could get even better film quality and keep scatter radiation to a minimum. So the minimum collimation would be just smaller than that image receptor. So again, you don't want to go beyond the parameters of the cassette itself. So in the state of California, the state of California mandates that you should have a visibility of 3 sides of collimation. This is to show that you did indeed collimate the film and you took the proper precautions to reduce patient radiation dose. Another thing is to keep in mind is to use the proper sized cassette or image receptor for the part you're imaging. So if you are imaging, say, a wrist, you wouldn't expect to use a 14 by 17 inch cassette on a wrist when you could essentially use a smaller cassette like your 8 by 10. So again, think about the required anatomy that should be visualized in every view and collimate to include that anatomy, but nothing else. But remember, you may still get some pieces of anatomy in there and you are still responsible for whatever you image. So here we have an example of an A to P open mouth view. So again, we had that example of the A to P open mouth view where the patient was poorly positioned. But here we can see, if we go back to our evaluation criteria, we do see lateral masses. I can see the TPs, I can see DENS and C2 vertebral body perfectly. So that area is good. However, we don't need all of the entire skull in view if we are just focused on our A to P open mouth, or the C1, C2 region, I should say. And you want to make sure when you are x-raying the patient, you don't want to have all this radiation go into their orbits, into their eyes. So even though this probably was done on an 8 by 10 cassette, it's best to collimate it as tight as you can just to focus on what you need to focus on. So it says only one border of collimation is visible. So you can see at the top, this green portion here is to show that this was the area of collimation, but we don't see on this side or here that any collimation was done. So it said, so without that, there's no way to prove that precautions were taken to limit radiation dose. And as you can see, this patient was just blasted with radiation right into their eyes, unfortunately. Not to say that that's they're going to go blind or anything right away, but you want to make sure you limit that as best as you can. Alrighty, next we have a lateral cervical example here. And when we're taking a lateral cervical spine, you want to make sure that we are getting at least from our sella turcica down to our C7 segment. So I can definitely see the sella turcica. And here in 1, 2, 3, 4, 5, 6. I think this is probably C7 here as best as we can see it. So like I said, as best as we can see it, but C7 to T1, C7 T1 isn't really visualized due to the shoulder. So that's not necessarily a deal breaker because some people, some patients have broader shoulders. Sometimes it's a little difficult for patients to lower their shoulders as best as they can. So other things can be considered, like doing a swimmer's view, which is a view that we specifically use to assess C7T1. Another thing, we do see good collimation, as you can see in this green highlight, that three sides, here's side one, side two, and side three. So proper collimation, or three views of collimation has been used. However, again, we have to make sure that their eyes, the patient's eyes, aren't getting any of that radiation dose as best as we can, as best as we can get it. So a proper collimation would be if we were to cut it there, just to make sure that their eyes are safe. So digital systems are often set up to crop out the collimated white area around the edges of the image receptor. Sometimes it can make the actual sides of collimation a little difficult to see. That's because, like it says, this was already built in for these systems. So here's an example of an A to P spot hip view. So as you can see, if we go back to the other examples of seeing what the collimation looks like and compared to what this collimation is here. So if we go back to the lateral cervical spine view, we can see that the blur between what was collimated and the actual image. If we go here, you can see that there's a sharpness at the where the collimation is. There's no white border visualized around the image, but this white border is replaced by a black border. So all of this area here, so we don't see that blur between what was outside the image and the actual image. So what we're actually seeing is the digital system making it a little more, I guess, aesthetically pleasing to the eye, and this is called post-processing masking. So only done on digital imaging. When it's applied, just make sure that you're not cropping out any of the pertinent anatomy that you should be seeing on here. And again, like I had mentioned before, you're responsible for analyzing every piece of anatomy that is on the x-ray. So even if you're just taking, say, this hip view and you're obviously focused on the hip, but also make sure that you are responsible for, say, assessing the SI joint, because that's still in the view, or a little bit of our pubic rami or ischial tuberosities. So next, on film quality, is there evidence of patient motion? So usually if we think that there's patient motion going on, you would see a blurred image. So you want to make sure that exposure times are as low as you can get them. Sometimes it can be a problem with children and elderly patients who both tend to be on the unstable side or the fidgety moving side. You can see this either on digital analog systems. It's pretty, sometimes it can be tough to avoid. You may also see a blurred image from poor contact between the film and the screens and the cassette if you're using an analog system. Um, Also, if the cassette is warped, meaning like the inner parts of the cassette are bent in a way, that can also result, sorry, in poor contact between your film and the screen inside the cassette. So here we have an example of motion blur. You can see on the image to our right hand side, it almost looks like there's almost in a way it almost looks like there's a double exposure because um, you can see like there's two aspects of the soft tissues. It almost looks like there's two um, cortices of some of the ribs. And you can just see it's just blur um, all the way around. You can even see at the mandible what looks to be two cortices present. So as you can see, retaking it. Sometimes remember, patient instruction is very important. Tell them, specifically tell them don't move, or you can have them hold their breath if necessary, if that'll help with the motion, with reducing any excess motion. Here we have a partially blurred image due to poor film screen contact. So we can see at the, as you're looking at digits 1, 2, and 3, those look pretty uh, properly visualized. But as you can see at digits 4 and 5, there's this blurring because the film and the cassette were not touching each other enough to ensure of a clear image. Alrighty, next, is the film density or the exposure, is it too light or is it too dark? Um, so it says here this discussion is primarily focused on our analog systems, so our film-based systems. So film density, or you may have heard, or you may remember optical density, is the degree of blackness on the film. This isn't to be confused with the density of the patient themselves. The film density is directly related to the number of X-rays striking the film. These are directly related and controlled by MAS. It's also related to KVP, but MAS is the primary culprit. Also influenced by processing. So a film with proper film density has the right amount of overall blackness so you can visualize the necessary anatomy, and even when we're talking about KVP, proper contrast as well. So if a film is underexposed, so there's not enough X-rays struck the film, that image is going to come out very white. So we need more X-rays for the retake. The number of X-rays, again, is controlled by MAS. So if you have an image that's too white, you may want to consider doubling your MAS to help balance that out so it can come a little darker. However, if you have an image that is overexposed, that's going to come out as too black. It's going to come out too dark. So too many X-rays struck the film, so we need a little less. Therefore, we should consider cutting that MAS by half. KVP also influences the film density. However, it affects other factors such as penetration, scatter radiation, patient dose, and more importantly, contrast. Um, Increasing the KVP by 15% will give you the same result as doubling the MAS. However, it will influence other aspects um, of the film that may or may not influence the density. So instead of changing the KVP, this is where we have this fixed KVP technique. So this is why when you guys are looking at your different body regions, we have a set KVP for you guys to memorize and to know, so you wouldn't have to change anything for that, and essentially you would just focus on the MAS when you're taking an image. Um, Also, the film quality is influenced by processing, the temperature of the developer, the freshness of the developer also, making sure nothing's expired. So here we have an example of an A to P lumbar spine view. The FFD, or focal film distance, was taken at with the patient, well, was taken with the X-ray tube at 40 inches from the image receptor or from the cassette. KVP was 80, and that's a fixed KVP. The MAS, after all the factoring, was 25, and the cassette that they used was a 14 by 17 inch regular cassette using a Bucky technique. So they used a grid. And as you can see, this image came out very, very underexposed. So there's too much white. I can barely make out those vertebral bodies, and I can't even see the sacrum or the SI joints. So in order for us to ensure a proper or better density image, we should consider doubling the MAS. So again, MAS was at 25. We should consider retaking it at 50, and everything else is going to stay the same. The FFD is going to stay the same. The KVP is going to stay at 80 because, again, it's a fixed KVP technique. And we're not going to change the cassette, and we're going to keep it in the Bucky. Here we have a neutrolateral spine. As you can tell, as you're looking at it, this image is very, very dark. We have the FFD, the focal film distance, at 72 inches. The KVP is 70. MAS is 22. And the cassette we used was a 10 by 12 regular cassette using a non-Bucky technique. So we did not use a grid, a built-in grid for this system, for this view. So as you can see, very, very dark image. This was overexposed. Therefore, we should consider cutting that MAS in half, to, bringing it down to 11, keeping everything else the same. So again, the FFD remains the same, the KVP is going to remain the same, and the cassette and technique that we use will all remain the same except for that MAS. And this is what it shows as a retake. So we can see, we can appreciate the vertebral segments, the posterior aspects of our vertebral segment. We can see the soft tissues, the posterior soft tissues, and even the anterior soft tissues and trachea and pharynx as well. Alrighty, next is to consider the contrast. Is the contrast too high or is the contrast too low? So contrast can be defined as the difference in optical density between adjacent anatomical structures. So in little words, are we appreciating enough shades of gray? So a sharp difference in the optical density between adjacent anatomical structures. So if we're talking from fat to muscle, or from muscle to bone, or from fat to air, those kind of things. Um, so a sharp difference between those adjacent anatomical structures would be of a film with high contrast. So high contrast means too little shades of gray. So we're only going to really see a lot of black and white. If we have an indistinct difference in optical density between adjacent anatomical structures, that would be of a film with low contrast. That would mean we have lots of shades of gray, or maybe too many shades of gray. So we have three different examples looking at this low contrast view. We can see primarily between fat and muscle, if we're looking at the posterior aspect of our the cervical study, so the posterior uh, fat, subcutaneous fat, and nuchal ligament, you can see that the border between again fat and water are very indistinct. As you can see on the optimal contrast, we can see very good delineation between fat and water. You can also see it pretty great on the anterior aspect as well. You can see the difference between fat and water on the high contrast, but if you look closely at um, the base of the skull, you can see that it's very whited out. So I'm not appreciating enough shades of gray. If we go look at this optimal contrast, I can make out the sella turcica very, very well, as opposed to that high contrast. I can see the difference between the thicker cortex of the outer table of the skull, as opposed to that high contrast. I can see a little more shades of gray in the vertebral bodies, um, in the optimal contrast compared to the high contrast. And then another example, just showing very, very low contrast, too many shades of gray. Again, very indistinct between some of the subtle differences and anatomical structure. So again, between that posterior subcutaneous fat versus our water dense muscles and ligaments. Very, very tough to see on that super low contrast. Almost can't even make it out on that super high contrast. And again, looking at the bone, the entire base of that skull is completely whited out. I'm not appreciating um, the like the mastoid air cells or the sella turcica or anything like that on this super high contrast, as I should see with this optimal contrast. So next one, we're still talking about contrast. The contrast of an analog system is determined by factors including your screen film combinations, KVP, as we have just went over, and scatter radiation as well. The screen film combinations have already been predetermined for X-ray setup, so no worries about trying to figure that out. Um, to ensure proper contrast, the film shouldn't be expired and the screen should be in good working order. Obviously, if you were actually um, taking these X-rays in real time. Um, Proper screen film combinations are only responsive to radiation exposure over a certain range. So you have to only pick exposures that'll fall within that range. And again, proper KVP is should be utilized. So KVP and the contrast are inversely related. So if you have a high KVP, you have low contrast, therefore you'll have more shades of gray. And then if you have a low KVP, you'll have high contrast, therefore fewer shades of gray, so that will look more black and white. And again, we already have the KVP set up for you guys just so to ensure proper contrast if you were to take this film in real time. Now going on to scatter radiation. Scatter radiation diminishes the quality of the film by striking the film, providing no useful anatomic information, and fogging a film. So there, as the name suggests, it scatters. It's going to go in any direction it pleases. This fogging will create the appearance of decreased contrast or more shades of gray on the film. It is never beneficial for scatter radiation to strike the film. More scatter radiation is produced by the more tissues that are exposed to the X-ray. Sometimes you can't help scatter radiation, but you can reduce it as best as you can. So the first method is using a grid. The second is reducing the amount of tissues that is exposed. So you can accomplish this by collimating to only the pertinent anatomy that you need. Or you can, if you have a bigger patient, sometimes placing them in an alternate position, such as lying them down, to help diminish the thickness can better the quality of the film and decrease scatter radiation in the same breath. So here we have an A to P pelvis view. We perform this at a 40-inch FFD focal film distance. The KVP is 80. The MAS is 50, and we use a 14x17 regular cassette using a Bucky technique, so we did use a grid, and the patient was standing in this case. As you can see, it was a properly done image. However, the contrast could be better. You see there's way too many shades of gray. Here we have the same patient. We perform this also at a 40-inch FFD. The KVP is still 80. The MAS is still 50. The cassette is still a 14x17 regular cassette, and we still use the Bucky technique. The only change that was done was the patient was now supine, so lying on their back, and you can see how much of a difference and how much better the contrast was just by lying the patient down. And we can now see that there is something going on at this right acetabulum. We see that there's a lucent lesion at the root of the acetabulum that you can kind of see on the first view with the patient standing, but obviously you can see it much better just by dispersing their tissues just a little better. Alrighty, continuing on with film quality. Are there any darkroom errors? So here are some things to consider if you are planning on using film and processing them in a darkroom. Is the film exposed to light? Do you have film sticking together in the processor? Are there guide shoe marks? Are your rollers dirty? Are there any foreign materials that are in the cassettes? Static electricity. Any problems with the chemicals? So it is important to do quality control every day when you have a dark room. So here we have an A to P pelvis view. Obviously, we are not fully appreciating the entire pelvis. We're only seeing that left side. So this was a light struck film. So the entire viewing left, or the patient's right, because here's a marker right here. It's a left marker, um, is homogeneously black. It's all black here. And we can't appreciate the entire anatomy. So obviously this film needs to be retaken, and making sure that you're using film that has not been exposed to any light. Here we have a lateral chest view. You can see that there are these white lines that are coming across the patient's chest. So multiple vertical opaque lines consistent with guide shoe marks. These are caused by the improper positioning or springing of guide shoes and the turnaround assembly of the machine. They are parallel to the direction of the film movement through the processor. So as you can see, this arrow here, the direction of the film transport is going down, and that's the direction of those lines. Again, quality control, making sure you have somebody that can come in and service the processor to make sure that everything is top notch. Oops. Okay. Next, we have an A to P pelvis view. Again, we also see multiple vertical lines coming across the film. In this case, these lines, if you were to measure them, they occur at 3.1416-inch intervals. So these are known as pi lines. So the name pi, given that value 3.1416. This is due to either dirt or a chemical stain on the rollers, and these are perpendicular to the movement, to the direction of the film movement through the processor. So the guide shoe marks are parallel, the pi lines are perpendicular. So for this one, the proper cleaning of the roller should be done in order to eliminate this from happening. Alrighty, here we have an A to P ankle view. As we can see, everything looks pretty good for the most part, but we see this little opaque thing. If you look closely, I think you can see little legs on this thing, and this ended up being a little ant. So just making sure that you should make sure the cassettes are clean, and I'm making sure no other little buggies are around to get into the cassettes or any of the screens. Here we have an A to P lower cervical spine view. We can see um, these black branching, tree-like artifacts that are running all the way down the cervical spine. This ended up being static electricity. Obviously, the film needs to be retaken because all of the static electricity is covering majority of the spine. Making sure that the processor is properly grounded, darkroom humidity is not too low, and making sure if you do happen to touch the screen, make sure you're not dragging your feet if you have carpet or anything like that. Um, Here's just a little blurb on how processor chemicals and temperatures can affect the image. So it says severe differences can occur in radiographic densities as a result of mechanical or chemical problems in an automatic processor. These 4 radiographs of a pelvic phantom were all exposed with the same calibrated X-ray unit, same cassette, technical factors, and collimator shutter pattern. However, um, it was processed in different processors of um, varying quality control. So as you can see, the first image probably looks the best out of all of them. The second one is underexposed. You see it's too white. The second one actually doesn't, I mean, the third one doesn't actually look too bad either. And then that last one is overexposed. It's too dark. So again, daily quality control testing, as you can see, the last part of this whole little blurb, daily quality control is essential in order to um, properly have good diagnostic quality imaging. Alrighty, next. We kind of went over some artifacts as with that little ant or the static electricity. Artifacts can come from different sources. The most common causes of artifact are usually on the person themselves, whether it's clothing, their hair, sometimes jewelry. So to ensure that there aren't any outside artifacts at the very least, making sure that the patient's always gowned up, their hair is put up if possible. All jewelry should be removed in the area that's being radiographed. Um, any equipment is properly maintained and out of the way. The two main dangers of of having artifacts: you could hide significant pathology, or the artifact can be mistaken for significant pathology. So here we have an A to P lumbar spine view. And as you can see, this patient has this very nice chain around them, numerous metallic chains overlying the lower lumbar and upper pelvis. So obviously, this this patient was not properly gowned, and they failed to tell the tech or the doctor, hey, I have this chain around my waist. I should remove this. So obviously, this film needs to be retaken. Alrighty, here we have an A to P pelvis view. Um, Not bad overall. The only issue with this one, the marker is covering the pertinent anatomy. You want to make sure when you have a pelvis view, you want to see the entire pelvis, which includes the iliac crest. I don't know if something is going on at that portion of the iliac crest because the marker is in the way. We also see a button overlying our L4 vertebral body. Um, the button can be confused for a pathology. Somebody might think that's a lesion, maybe a metastatic lesion. Um, but just to make sure, like again, proper gowning of the patient, And also proper placement of your markers is also very important. So when placing markers, I would suggest putting it in like the any of the extreme corners if you can, just to ensure that I do see marker, but it's not in any way obscuring any anatomy. Alrighty, here we have a flexion cervical spine view. Looking at this, we can see like this multiple streaks overlying um, all of the visualized osseous structures. This actually ended up being hair. So again, sometimes hair can look pretty dense on X-ray. So again, it's very important to have the patient pull it back or put it up if they have long hair. Alrighty, another example, we have an A to P lumbar spine view. We can see that there's this odd uh, bright or metallic looking wire that is overlying um, the viewing left portion of this image. So the circular metallic density overlying the right femoroacetabular joint. This was a high voltage wire to the tube that came loose and ended up hanging in the field of view. So it says it's not covering vital anatomy. However, there's a loose wire. So obviously this needs to be put back in place and away from anybody potentially touching it and causing any harm. Okay, another example here, we have an A to P lumbar spine view again. And for the most part, everything looks good. I mean, the density could be a little better, but we do see this structure here. It looks like something either end, and there's like a little arrow. This ended up being a cardboard tab from the lid of the film box, ended up getting stuck in the cassette. So make sure before you input any film, if you are using an analog system, to make sure your screens, your cassettes are clean and free of any paper, again, bugs or something like that. Alrighty, next, is there only one exposure on the film? So it's important to have a system when you're taking an x-ray. You want to make sure that you have a dedicated area for any unexposed cassettes and any exposed cassettes. So this is specifically if you're talking about an analog system, um, but it can happen with with digital systems too. Um, but not the unexposed versus exposed cassettes. Losing focus and not using a system while taking x-rays may result in exposing a single cassette two or more times before developing. So um, if you took an x-ray, whether it's an analog or digital film using one of the cassettes, and you forgot to take up the image for on that cassette and then use that same cassette, obviously you're going to have multiple exposures on this. So the views obviously need to be retaken separately. So here we have an example of a chest view. And if you look closely, particularly at it's like the shoulder areas and the clavicles, there's like one I didn't outline that pretty well. So here's like one humeral head, and it looks like another humeral head there. Here's what it looks like part of the acromion here and another acromion there. Or if you're looking on the left side, um, here's the superior angle of the scapula and this one here. So it looks like we have double the chest. And even looking at the ribs, we can see multiple cortices present. The image doesn't look too blurred, so if when we talked about the motion blur, you can see like overall the image was blurry, but this one you have two sets of bones overlapping each other. So this was due to a double exposure. So they took the chest X-ray of this patient on the same film twice. So obviously this needs to be retaken singularly. Lateral cervical spine view. I don't know about you guys, but some people have lumbar spine in their skull, apparently. Uh, Kidding, but as you can see in this lumbar spine view, you can also see that an oblique lumbar um, an oblique lumbar spine view was also taken. So obviously, the oblique lumbar spine view and the lateral cervical spine view both need to be retaken separately. Alrighty. Next, we're going to talk a little more about digital imaging. So there could be a lot more other film quality issues that can happen if we're looking at a digital system or a computer system. You can classify these into two broad categories, either image acquisition errors or image processing errors. With the image acquisition errors, a lot of these we talked about with analog systems that can also happen with digital systems. So double exposure, the poor collimation, over under exposure, and something called kinking of the image plate. Some are specific for digital imaging, such as using a grid with less than 60 lines per centimeter, or backscatter radiation. If we're talking about image processing errors, scratches, dirt, dust, ghost image, malfunctioning of rollers, software errors can all occur. So here we have an example of an angulated L5S1 spot view. And this is from a computer system. Here we can see that there are multiple linear opacities present. This is due either from dirt on the image receptor itself or damage of the image receptor due to the rollers pulling the plate through the image reader. So with a computer-based system, the cassettes have, instead of using film, they have a plate in there inside the cassette that captures the image, and it's fed into a computer to take up the image, and then that plate is completely washed away. The image on the plate is completely washed away, and then you can reuse that cassette over and over again. And use it right away instead of having to wait for the film to be processed. So making sure the image receptors, meaning the cassettes themselves, should be inspected and properly cleaned. Here we have another example from a computer system. This is an A to P pelvic view. And you can see that there are these diagonal wavy type lines traversing through the entire image. This is due to using a grid with too low grid line rates. So this is less than 60 lines per centimeter. So um, having a good grid system is important. Here we have an A to P abdomen view, also from a computer system. Looking closely, you can just see that there was evidence of a chest x-ray that was performed that's been superimposed on this x-ray here. The chest radiograph was not completely erased from the plate that's in the cassette. This is a little different from just a little different from a double exposure, but this is known as a ghosting artifact because the image was fed into the computer receptor and picked up, but it wasn't completely washed away. The chest radiograph, I mean. Um, so with ghosting, you may see just a little less than you would from a double exposure. Double exposure, you would probably see just as much density from one of the images as to the next one. Some other things to be aware of, um, off-focus radiation. So I believe you guys went over a little off-focus radiation back in physics. This is a small number of electrons that stream from the cathode to the anode and may bounce off of the anode upon impact and splash over to hit other parts of the anode. So it'll from the cathode here, and it'll bounce where it needs to, but also go in other aspects of the anode. And it says they can produce X-rays from parts of the anode that are not part of the target itself. These off-focus X-rays may strike the patient outside the collimated area. So off-focus radiation is reduced by enveloping the tube in metal, so even further collimation, so like an aperture. So I believe you guys in physics, you guys talked about like those apertures. You can have a cylindrical aperture or like this cone-shaped aperture to help further um, um, ensure that the collimation is proper. So we have this example of this lateral lumbar view, and we have the area in question that is collimated, but you can see that you could definitely see soft tissues surrounding the area of collimation, as you can see here, and then a posterior aspect. That's what we are considering is the off-focus radiation. So the areas of the soft tissue outside of the collimation that has still been essentially exposed and in view of on this image. Here we have an example of a lower cervical spine view. So again, here is our area of collimation, and you can see on the outside a little peek of, say, the person's ears and a little bit of their head. So again, another example of off-focus radiation here. You can also see part of their shoulders as well. Again, off-focus radiation there. And that's the end of our slideshow. So hopefully, me explaining all of these slides, going a little more in depth, help you guys. If you do have any questions for me pertaining to this PowerPoint, please let me know. Um, I will be asking some questions in regards to this PowerPoint um, throughout the time we are taking this course, whether it's in our weekly quizzes or in our um, final written exam that you guys will have in week 8. Okay, so again, I hope this helps you guys. Again, if you have any other questions, don't hesitate to email me. I thank you guys, and I hope you have a good day.